We have an eminent panel of speakers from different parts of the India. Warm welcome all of you. Today's moderators are Dr. Sonam Nisar, consultant oculoplastic surgeon from Shankar Nethralaya, Chennai, Dr. Anju Chandran, consultant from Comtrust Eye Hospital. The first talk is on the evaluation of eyelid swellings by Dr. Aparna K. Sharma. She finished her fellowship in oculoplasty from Aravind Tirunelveli, and now she is a consultant at Chaitanya Eye Hospital, Trivandrum. Welcome all of you.
A very good morning to one and all. I am Dr. Aparna KS, and today we are going to uncover the mystery of generalized lid swellings. First of all, thank you Soumya ma'am and KSOS for giving me this opportunity. Generalized lid edema can be a diagnostic challenge to many of us because the etiology of this condition is highly varying. It can be a trivial hordeolum, or it can be the herald of severe systemic diseases or even neoplastic conditions also. So today I am going to give you a brief outline regarding various etiologies of generalized lid swelling. First, about infectious causes. Preseptal cellulitis is an inflammation of the tissues anterior to the orbital septum, which is characterized by erythematous, painful lid edema. Sometimes it can be associated with chemosis or low-grade fever also. But whenever there is dangerous signs like proptosis, limitation of eye movements, optic nerve involvement, think about orbital cellulitis, or even the spectrum can extend up to life-threatening conditions like cavernous sinus thrombosis, which needs aggressive management. Lid edema can be due to collection of pus itself, as in the case of lid abscess or lacrimal abscess, which needs incision and drainage. Sometimes the culprit can be nearby, as in hordeolum, dacryocystitis, or even acute conjunctivitis, but sometimes it can be away from the eye, as in this case of pharynculosis of the scalp resulted in dependent edema of the eyelids. Whenever there is vesicles, think about viral infections like herpes zoster or simplex. Whenever there is painful rashes, think about bacterial infections like erysipelas. Blister beetle dermatitis is caused by pedrus beetles, which is characterized by pustular or vesicular lesions on an extremely erythematous skin. And don't forget to ask about history of insect bite, especially in case of children. Coming to inflammatory causes. Pseudotumor is an orbital inflammation without any identifiable systemic or local causes, and blepharochalasis is a rare episodic inflammation of the eyelids, which is characterized by stages of acute attack of non-pitting edema followed by a quiescent stage of cigarette paper like thin skin. Patients with dacryoadenitis will have inflammation, redness and swelling more towards the superior lateral aspect of the orbit. And whenever there is bilateral dacryoadenitis, try to rule out various underlying systemic or autoimmune conditions. Lid edema due to allergic etiology will be usually painless. It can be a simple allergic edema on exposure to various irritant to life-threatening angioedema also. Sometimes it can be the masquerade of underlying neoplastic conditions. So always make a habit of checking for lymph nodes because it can change the whole treatment plan. Vascular lesions can present with lid edema with a bluish tinge. Here we have to look for pulsations, compressibility, variation with cough or Valsalva manner. In case of trauma, ask a detailed history regarding the mode of injury, type of injury, time of injury like that. And whenever an aged patient is coming with a bumpy lid, think about dermatochalasis or fat prolapse due to thinning of connective tissues or loss of elasticity of skin. Sometimes it can be a manifestation of underlying systemic conditions also. So always ask a history of increase in the edema during morning hours, especially in case of renal diseases. And in a patient with a dysthyroid status, look for various lid signs of thyroid eye disease. Sometimes the underlying globe itself protrude and present as a lid swelling, as in this case of microphthalmos with cyst or a case of staphyloma like this. This is a case of a 7-year-old child with upper lid swelling, and there was a minimal limitation elevation, so I sent for imaging, and that turned out to be frontal lobe intraparenchymal abscess. So the child was immediately referred to neurosurgeon. This elderly gentleman with a long-standing history of swelling in painless swelling, firm in consistency, I was expecting a vascular swelling actually, but on eversion it was a simple conjunctival inclusion cyst, which needs simple marsupialization even without imaging. And this is a child treated as chalazion, but on eversion it was a foreign body And an interesting case of a child who is studying in 4th standard with upper lid edema and congestion in the superior bulbar and pharyngeal conjunctiva. And her mother bought this bottle full of different varieties of insects. And she revealed a history of keeping insects in the fornix in order to induce conjunctivitis. And motive is just to avoid exams. So lid edema can be an important symptom as well as sign. It can be life-threatening or even vision-threatening also. So always we should have a systematic approach to reach the diagnosis and give prompt treatment. Thank you.
Thank you, Aparna, for that beautiful presentation. We'll take questions at the end of the session in interest of time.
And now we'll have a second speaker who is Dr. Feroz, who needs no introduction. She's from Bangalore and from Horus Eye Hospital. She's going to be telling us some masquerades. Oh, I have to see there. Okay. Okay, fine, yeah. Yeah. Hi, everyone. Good morning. And thank you, Soumya, for having me here. And it's really, really honorable to be standing here, especially in Thrissur, where I have started my journey as a doctor. And my HOD is sitting right here. So that is how I got trained. So I'm going to take you through masquerades in eyelid swelling. I'm an ocular oncologist and a plastic surgeon. So we'll go in terms of few masquerades which kind of smiles at us, and sometimes, you know, we are also kind of amused at what things turn out to be, and that's what I'm going to go today. Okay, so these are my affiliations. I'm also honored that I'm part of the Malabar Cancer Center, which we have an ocular oncology department, which has been started for the past. And a lot of surprises there. And now to the next speaker, Dr. Akshay Nair from Mumbai. He's a freelancer and also associated with Aditya Jyot Eye Hospital. And he's going to be talking about lower lid blepharoplasty.
Thank you. So, this one. No, first slide, please. That's what I'm saying. Go to the first slide, no? All right. So after the beast of cancer, we come to the beauty of the eye, and we'll have a beast presented. We'll be talking on lower lid blepharoplasty. So, well, technically not a lump and a bump of the eyelid, but when patients do come with requesting for a lower lid blepharoplasty, it's often because they have very, very localized swelling, or what they call under eyelid bags, or excessive hooding of the skin on the upper eyelid. So on my talk, I'm focusing only on lower lid blepharoplasty. And these are the 5 subheadings that I'll be talking about. Basically, assessment of a patient. What do we look for? How do we advise what type of blepharoplasty is needed? What complications are possible? And now, what adjunct procedures can we do along with a blepharoplasty? So the first is to assess the patient. So there are different things that a patient can present with when they come for a blepharoplasty consult. So the aim is to understand who is a good candidate and who is not a good candidate, and if you are a candidate for a blepharoplasty, what is the route for surgery and what surgery would you do? So patients typically have lower lid fat prolapse. This is essentially the orbital. There are 3 fat pads in the lower lid: the medial, the middle, and the lateral. The medial is a continuation of the intraconal orbital fat. The middle and the lateral are separate, isolated fat pads. They can even have malar mounds, which are fluid bags on the cheek, which often get mistaken for lower lid fat prolapse. And in all patients who present, especially with a subacute history of eyelid swelling, we need to rule out thyroid eye disease. So this is a patient who's coming with a lower lid fat prolapse, 28 or 30 years old. How do we know this is fat and not, fluid bags or anything else? A good idea is to have them look up. When they look up, the septum and the inferior rectus of the lower lid relaxes. In the lower lid relaxes, so the fat bulges out more prominently. The appearance of fat bags worsens on up gaze. And when you ask the patient to look down, the inferior rectus tightens, the septum and the fat retract, and the appearance improves on down gaze. So this is a patient whom I just need to tuck that fat under the subperiosteal pocket or even excise it, and the patient will have a smooth lid cheek junction. Now compare that to an elderly gentleman who again is coming to you with the similar complaints. I have lower lid fat bags. Ask the patient to look up, it becomes more prominent. Ask the patient to look down, the fat pads have disappeared, but you can see there is still some excess skin. So this is a patient in whom I'd want to do a transcutaneous blepharoplasty, tighten the skin, and also look at the inferior scleral show in this patient. You can see that there is about a couple of millimeters of sclera that you can see on the lower lid. So you'd want to also tighten the canthus there, lift the eyelid, maybe a lateral tarsal strip. So this tells you a good idea of how to do. Now these are malar mounds. These are patients whom you do not want to do a blepharoplasty in. These are fluid bags on the cheek. The best way to treat them is to refer them to a competitor because there is no effective treatment for malar mounds. Do not miss ptosis. Now this patient has excessive skin hooding on the upper eyelid, but don't miss the right eye ptosis. You'll do a bleph, you'd end up not correcting the ptosis. The patient is not going to be happy. So especially in these patients with fluid bags on their cheeks, you want to rule out thyroid eye disease before jumping in for surgery. So a lot of young patients come to us seeking for a blepharoplasty consult, and there are some patients who fit into a case where I'd offer them a lower lid filler, and some patients whom I'll do a blepharoplasty. So there is a hills and valley concept. Now if you look at the patient on the left, there is a very prominent lower lid fat prolapse that extends. You can see that there is the medial fat bag is also prolapsed, the middle and possibly the lateral. Again, the fat prolapse is all over. Whereas here, the patient has only a medial fat bag prolapse. So, and also the prolapse is very gentle. It's not too prominent. Can I mask this hollow with filler? Yes, I can, because it doesn't go past the mid-pupillary line. So that is a rough guideline that I use. That's what I thought because of the crepey skin, but if you see the post-op, again, make the patient look up, the fat bags become very prominent. It's a telltale sign that these are fat prolapse bags. But if you do so this is a patient who had a transconjunctival blepharoplasty, the medial and the middle fat pads were tucked under the periosteum fat transposition, and the aim of blepharoplasty always is to have a smooth lid cheek junction, but the patient on the left received a filler injection, and the lid cheek junction could be smoothened out with a filler. She is 23 years. I don't want her to undergo a blepharoplasty now at this stage. So based on the prominence of the fat pad and also the depth of the valley, whether you can fill it with filler is when I choose this is a patient for filler, this is a patient for fat conjunctival blepharoplasty. I won't go into the surgical video in depth. I'll quickly just show the route. So inferior fornacial or transconjunctival, give a little bit of local anesthesia. 4 mm under the tarsal border is where the incision is made. I prefer making my incision with a radiofrequency cautery. In your initial cases, it's good to make a complete linear incision and not localized incisions. This is a post-septal approach. You open the conjunctiva and the retractors, and you don't even need to go up to the retractors. You'll immediately see the fat pads pop up. There's something known as a globe retraction, and you depress the globe and the fat prolapses out. The fat needs to be injected a little bit with anesthesia, gently cut out, or you can use your cautery to cut it. Don't debulk it completely, just excise enough so that the fat bag's prominence reduces. You do not want to excise too much so that you create a skeletal or a hollowing look. In patients who need a transposition, you just need to extend the incision, visualize the inferior rim of the orbit, create a periosteal pocket, and push the fat bags underneath that. These are patients who've had transconjunctival blepharoplasty. They can be as prominent as this or as subtle as this, but the effect remains the same without a scar. Again, a young patient, he also underwent. So in this patient, all I want to do is trim out the fat a little. I don't even need to transpose it. Little fat excision is adequate. But in this patient, I would do a transposition because the fat prolapse is pretty prominent and also he's a little older. So here the fat the middle and the medial fat bags are identified, taken with a proline suture, and a subperiosteal pocket is made under the skin and tied there so that it volumizes the cheek and smoothens the lid cheek junction so that the patient has a very clear, smooth transition with no bumps or humps. Is this the only way? No. A lot of patients also need transcutaneous blepharoplasty, and in transcutaneous we excise a little bit of skin. But how much skin needs to be excised, that is the most important part. Otherwise, it's technically a simple surgery. So I'll quickly run through that video, focusing on the part of how much skin needs to be excised. So what we need to do is make a subciliary incision. Before that, we mark how much skin is to be needed. So this is called the pinch test, where we pinch a little bit of skin, and the minimum amount of skin that you can pinch without the eyelid moving is position. Now, if I pinch this much, look at the eyelid coming down. This is going to cause ectropion. This much skin, the eyelid position doesn't change. So the minimum amount of skin that you can pinch and lift without the eyelid margin coming below on the conjunctiva, on the cornea, is the amount of skin that you need to excise. So laterally it's a little more and medially it thins out. In these cases, I take traction sutures to pull and make the lid taut. For skin incisions on the lower lid, there is no fold to hide it, so I make incisions with cold steel 11 number blade rather than radio frequency cautery. Excise only the skin, try to save the orbicularis if you can. And once you've excised this is where you open up the orbital septum and look at the fat pads. Now you'd be able to identify the fat pads very easily here. You can differentiate between the fat pads. That's the medial, that's the middle, that's the lateral, and between the medial and the middle you will see a flesh band of pink structure called the inferior oblique. If you see it, run away from it, otherwise the patient will have possibly diplopia if you damage it. Now in this case we are excising the fat because this is a patient who had very, very prominent fat bags, and post-operatively you can see that the improvement is drastic. More importantly, a subciliary incision does not need to leave behind a scar. We can combine lower lid transcutaneous with an upper lid blepharoplasty also, which literally knocks off 15 years off the patient's face. This is transcutaneous. Things that we need to be aware of are complications. If you use cautery aggressively on the skin, in spite of a blepharoplasty, the patient looks far worse than what he probably looked before surgery. So these are kinds of scars that we need to avoid. Pigmented preseptal skin scars are very difficult to treat, which is why choose blade over radio frequency and close meticulously orbicularis and skin in layers. Try not to excise too much skin so that you don't see lid retraction, but if you do, immediately start using 5-fluorouracil injections or triamcinolone injections to prevent the scarring, and do not delay corrective surgery, because if you delay corrective surgery, you're compromising on functional outcomes. You don't want to sit on a patient with lid retraction but have the patient suffer the side effects of lag of thalamus and exposure. So if you've made a mistake, go in and correct it. And again, fat transposition. This is a case who's ideal for fat transposition. You can see that the cheek is very hollow. The level of amount of fat that is prolapsed is lot. You want to push it down. So I just put this case to show that how a case for fat transposition really presents. Adjunct procedures, you can add CO2 lasers, speak to a dermatologist and have them do that. It takes care of pigmentation and also rejuvenates the skin. Now this was a patient whom we did a fat excision. She just wanted the small medial bulges to be corrected. After surgery, she was happy. She had these hills and valleys. But then she came and said, it looks nice, but now my eye looks hollow. So it was, chicken and egg going there behind that, causing hollowing, fullness, taking away the fullness, leading to hollowing. So we then added a little bit of filler, and at the end, both the surgeon and the patient are happy. The aim of a blepharoplasty is to remove the prominence of the lower lid fat pads and create a smooth lid cheek junction. So to summarize, a thorough assessment is needed. A biggest red flag is active thyroid eye disease or a lymphoma. Like Fairouz said, I would have probably gone ahead and done a blepharoplasty, but you need to have your thinking cap on. counseling the patients and giving them realistic expectations. If patient comes and tells you, I want almond eyes like Katrina Kaif or Deepika Padukone, please stay away from these patients. At the end of the day, it has to be a customized management. One size of shoe doesn't fit everybody. What is needed in that patient should be offered to that patient, whether it's transconjunctival versus transcutaneous, and always adjuvant procedures like fillers, Botox, or lid lasers can be offered. So early recognition and management of complications is important to avoid functional issues that patients can develop. Thank you for your time, and thank you for the invitation, Dr. Soumya.
Thank you, Dr. Akshay, for that excellent tutorial. It's always a pleasure listening to you talk. Next, I call upon Dr. Marian Pauly. She's a consultant in orbit and oculoplasty and the head at Giridhar Eye Hospital. She'll be talking about when there is rubor, Kaller, and Dollar.
Yeah, thank you, Dr. Soumya, for giving me this opportunity. So I have put 3 pictures in this. Will you treat all these patients in a similar manner? So that's a question. I hope you will be able to answer that question at the end of this talk. So orbital infections can be either bacterial, fungal, tuberculosis, or parasitic. So coming to the stages, group 1 is preceptor cellulitis. This is basically for the postgraduates. Group 2 is orbital cellulitis. Then group 3 subperiosteal abscess. Then group 4 is orbital abscess. And group 5 is cavernous sinus thrombosis. So the clinical onset vary considerably. In any of these stage, patient can present to us. Causes periocular trauma or surgery or spread from a local infection, sinusitis, dental, dacryocystitis. So when you see a patient with a lid edema, suspecting infection, you have to ask a detailed history and or spread from a remote infection. Preceptor cellulitis is anterior to the orbital septum. We can manage it on an outpatient basis. The preferred antibiotic is amoxicillin clavulanic acid. Coming to orbital septum, we know the clinical features. So the main thing is we have to prevent the complications, mainly ocular, that is glaucoma, exposure keratopathy, arterial occlusion, optic neuropathy, panophthalmitis, then intracranial complications, then orbital complications like subperiosteal abscess and orbital abscess. So this is a case of dacryocystitis with the orbital cellulitis and later on abscess. This is the ring enhancing sign in CT scan. Coming to subperiosteal abscess. So in subperiosteal abscess, most of the time pediatrics, they present just with lid edema. Always ask the history of fever. So this child actually presented to our casualty in the morning with the lid edema. The doctor treated as allergy, and afternoon she presented like this. So she had subperiosteal abscess. You can see in this the abscess adjacent to the ethmoid sinus. So this is very, very important to identify the subperiosteal abscess. Then coming to the orbital abscess, most of the time eccentric proptosis and imaging is diagnostic. So differential diagnosis can be pseudotumor, thyroid eye disease. You have to rule out all the other inflammatory conditions. Coming to the evaluation, aim is to find the inciting event. History, very, very important. Always check for the other eye examination because we know it can cause cavernous sinus thrombosis. Then routine blood test, blood cultures, poor ill, but still you have to do blood cultures. Then culture of nasal swabs, if any drained abscess, etc. Children less than 9 years, single isolate, staphylococcus, more than 9 years, polymicrobial. Coming to the evaluation, imaging to detect sinus disease, extent of orbital disease, and classify the infectious process. So when will you do CT scan? Worsening clinical picture, decreased color vision, then signs of any CNS complications. MRI if you're suspecting a retained orbital foreign body, especially wooden foreign body. So when you see a patient with orbital cellulitis, the first thing what you should do is check the vision. All the ophthalmic examination was done, and then admit the patient. Don't send the patient immediately for CT scan or whatever. Admit the patient, start the patient on intravenous antibiotic. First option will be amoxicillin clavulanic acid or third generation cephalosporin. Then once the first dose of IV antibiotics is over, then you can send the patient for imaging. There are so many instances. Initially, patient was seen in OPD, then sent for CT scan, and the patient comes back with no PL or defective vision. So that we don't want to happen. In penicillin allergy, we can use vancomycin or fluoroquinolone, metronidazole if you are suspecting anaerobes. So monitor the patient every 4 hourly. Remarcate the zone of erythema or induration is the first sign of response to antibiotic. Then continue the treatment for 3 weeks. Add steroids when the patient is afebrile. Surgical management, suspect when suspect abscess when there is a progression of clinical signs. This is the high-risk criteria for surgical drainage of subperiosteal abscess, that is age 9 years or older, associated frontal sinusitis, non-medial large subperiosteal abscess, gas within the abscess on CT scan, recurrence after prior surgical intervention, radiological evidence of chronic sinusitis, acute optic nerve or retinal compromise, dental etiology of infection. So this is a case of orbital abscess which we have drained. Coming to the chronic infections, TB, rarely we come across, but still you can get, but the presentation is always different. She just presented with a lid edema. Then we have investigated her. You can see her CT scan. This is not very typical of acute infection. This is there are so many other differential diagnoses. So when Mando was done, Mando was positive. She's actually a non-diabetic, 8 years, a history of fever. And when we asked the history, there's a history of chronic orbital pain also. And he had double vision. She had double vision also. So treated as TB and she became all right. Fungal infections I'll just touch upon. Aspergillus and mucor are the most common. Aspergillosis seen in immunocompromised and immunocompetent. Treatment is primarily by voriconazole, but it is very expensive, so majority of our patients might not afford. The alternatives are amphotericin B. Then practically we are using itraconazole. So this is a patient who presented to us following with a chronic pain and lid edema. You can see that lid edema. When I was asking the history, she said she underwent some ENT surgery in the past. So when we did the scan, she had a fungal granuloma. It was an aspergillus, and she was treated with itraconazole as she could not afford voriconazole, and she became all right. This is the post-operative resolution of the mucormycosis. So we are very familiar with mucormycosis treatment because of COVID. Opportunistic infection, diabetic ketoacidosis, inverse and occluse vessel, early sign, early deep pain, rhino-orbital progression. This is very, very important to identify the mucor, because in mucor the characteristic of lid edema is it is like we have seen AO and pilot disc edema like that. Since the pathology is ischemia, you see edema without inflammation. So management, we can actually, it's a big thing to discuss mucormycosis. There's an article published by Dr. Santosh in IJO. So combined medical and surgical treatment, thorough debridement, correction of the underlying metabolic abnormality, amphotericin B is the preferred. Second line is fluconazole. Fluconazole and voriconazole not very effective. So in chronic retroorbital pain, always look for proptosis and lid edema, suspect chronic infections. Parasites, we commonly see diarrhea, cysticercosis occasionally. Cysticercosis is an anterior orbital involvement, presence with cellulitis like picture, treated with albendazole. So this is a case of a lid edema after 6 days. He presented to us after 5 days. Then we did a scan, showed a cyst with scolex. We have to confirm. We did IgM cysticercus. It was positive. Then treated with albendazole and he became all right. Diarrhea is very common in our part. Always presents with the periorbital cellulitis. Initially we think it is as infective, but looking at the fleeting lid edema, various characteristics of the lid edema, basically fleeting lid edema, like today edema, tomorrow no edema, like that. Imaging, ultrasound sometimes can help you, and antihelminthic treatment is not very effective, but we have tried ivermectin in our series. Excisional biopsy is diagnostic as well as therapeutic. Coming to the next set of inflammation, next set of lid edema, that is inflammatory, orbital inflammation, can be either specific or non-specific. Specific primarily granulomatous diseases, then the non-specific. So this is a young patient presented to us with lid edema. We can see the nature of the lid edema. It is primarily localized to the lateral orbit. So she had acroadenitis. You can see the enlarged lacrimal gland. She had a history of chronic otitis media, for which she underwent biopsy. That was negative for all the diseases, but however her inflammatory parameters were very high. So we suspected some sort of granulomatous, like GPA, granulomatosis, polyangiitis or sarcoidosis. We directly went ahead with biopsy in this case. See the scan, you can see the indentation of the globe with the mass. And it was granulomatosis, polyangiitis, and she did well with rituximab and steroids. So now this is another case of inflammation. So look at the color of the lid edema. So this edema gives you a clue that this is not infective, this is inflammatory. Is it allergy? In allergy, you will get the lower lid involvement also mostly. So then again, look at the ocular examination. You can see some chemosis near the medial conjunctiva. She had medial rectus myositis. All investigations done. It was non-specific, treated with the steroids. So an orbital inflammation takes a good history because you have to rule out so many systemic diseases, then investigate for any specific cause like granuloma, GPA, sarcoid, most commonly we see, then tuberculosis also. Steroids first line. Recurrence or inadequate response to steroids, to think about biopsy. Rheumatology consultation in chronic recurrences to start immunosuppressants. So this is another case which I would like to share. Is this orbital infection or inflammation? So you can see there is a lid edema, congestion, chemosis, and you can see restriction of abduction. But the characteristic thing is, it is more commonly seen in slit lamp. There is prominent episcleral vessels. So this is no infection, no inflammation. This is CCF. So you have to be very careful. So orbit is Pandora's box, history taking, clinical examination, radiological assessment, biopsy whenever necessary, and treat according to the cause. Thank you.
Thank you, ma'am, for the talk. Next, I call upon Dr. Anju for her talk on upper lid blepharoplasty.
Good morning, all. Thank you, Soumya, for the opportunity, and it is very heartening to see a full house today. After hearing all the experts talk, mine is a beginner's perspective. So anybody in the audience, can you identify who this is? Anybody? Okay, so how did Norma Jean Baker go from this to this? And what is the relevance in today's presentation? So if you look at her eyes, she has definitely undergone an upper lid blepharoplasty. So as early as in the 19th century, blepharoplasty has been reported, and the very term blepharon refers to eyelids and plasticos means to mold. So as you saw already earlier, it is a surgical procedure where the eyelid skin, the orbicularis oculi muscle, and the orbital fat is either excised, redraped, or sculpted for aesthetic or even for functional abnormalities. So we'll just briefly look at the anatomy again of the upper eyelid this time. So eyelid skin is the thinnest in the body, and it is unique for not having subcutaneous fat. And the levator palpebrae superioris, which is the main elevator or the retractor of the eyelid, it has several insertions, and one of the insertions is the reason for the upper lid crease. And it has two fat pads, and we have two fat pads, one in the medial and the middle, and the lateral is occupied by a lacrimal gland. So with aging, what happens is the skin becomes thinner. You notice dermatochalasis. There's associated fat prolapse, and also patients do come with brotosis, which is important in the management later because blepharoplasty alone would not be sufficient for the patient, and an associated blepharotosis as well. So you saw in detail how to choose a good candidate. The main indications once again would be dermatochalasis, blepharochalasis in thyroid eye disease once the active phase has subsided, and in patients who have had trauma and for cosmetic purposes. It's very, very important to have a detailed history, once again emphasizing on taking a history of bleeding diathesis and use of anticoagulants. And one thing which most patients would like to hide from their doctors is any history of previous surgeries, which you should always rule out. Corneal status and tear production need to be recorded in all cases, and a thorough preoperative counseling. You talk the patient through the surgical procedure so that they have a realistic outcome. Photo documentation is very important, both prior to the surgery and post-surgery as well. You always take a front photo, an oblique view, and a profile photo, which is a side photo. You should spend immense amount of time in just the preoperative marking, as was described by Dr. Akshay earlier. This is the skin pinch technique, whereby you pinch the excess amount of skin to make sure that you do not excise too much of the skin or the orbicularis, resulting in lag of thalamus later. And you should remember to keep always a minimum of 20 millimeters of the upper lid in order to maintain the anterior lamella. So I'll briefly run you through the surgical technique. So once the marking has been done, then you excise the upper lid skin, followed by excising a small part of the orbicularis around 4 to 5 millimeters. And depending upon the orbital fat prolapse, you excise part of the orbital fat after coagulation. And remember to take lid crease forming sutures from the orbicularis to the LPS. And closure can be done either by interrupted or continuous sutures. This is preferably done under local anesthesia where a mixture of lignocaine plus adrenaline is given for good hemostasis. So one thing that you would ask the patient to avoid is to restart their anticoagulants and blood thinners at least for a week. And I'll finish in a minute. And ask them to avoid lifting heavy weights. And as part of the healing, some people tend to develop pigmentation, so avoid excessive sunlight exposure and copious lubricants because there can be altered tear film disturbances. Complications: hematoma, asymmetry, lack of thalamus, ptosis, dry eye syndrome, orbital hematoma or compartment syndrome, which needs to be addressed quickly, lymphedema, and ocular motility disorders. This usually happens when there is excessive dissection. So this was one of my patients who had come with a history of previous 2 excisions already, but she was still unhappy. If you look at her, she kept complaining about the upper lid swelling that she had. And on palpation, that was actually the prolapsed lacrimal gland. So what she underwent was a bilateral lacrimal gland repositioning with blepharoplasty, minimum blepharoplasty under local anesthesia. And this is her at post-op, and she's much happier. So in interest of time, I guess we will have to skip the surgical video. Thank you all for patient hearing.
Thank you, Dr. Anju. And we are open to questions from the audience. If anyone has any questions for any of our speakers till now. If there are no questions, we can move on to Dr. Soumya, who is going to be our last speaker. Dr. Soumya, and she's going to be talking about when thyroid is the culprit.
Good morning. So this is a very common presentation of generalized lid swelling which comes to our OPD, but this will stand out with the lid retraction and lateral flare, lid lag, periorbital fullness and the staring look. Also look for the extraocular motility disorders, congenital congestion, superior limbic keratoconjunctivitis, and we should look for compressive optic neuropathy. So here thyroid is the culprit. So thyroid eye disease is an autoimmune disorder affecting the orbit in the 3rd and 5th decade of life with female preponderance, and 90% of patients are hyperthyroids. And this is the pathogenesis. The orbital fibroblast is the effector cell where it has insulin growth factor receptors and thyroid stimulating hormone receptor, where the corresponding antibodies will come and attack, and there will be increased glycosaminoglycose production, adipogenesis, and fibromyoblast proliferation, which leads to all the symptoms and signs of thyroid eye disease. So for evaluation, we should do complete ocular evaluation including diplopia charting and visual fields. We should do thyroid function test including TPO and thyroglobulin antibody. We have to rule out other autoimmune disorders like myasthenia gravis. The imaging is also very important. In CT is the most common investigation we do. In that we should check for fat hypertrophy, muscle enlargement, which is shown with the red arrow. Radiological activity we should check, that is seen with the inflammatory edema. We should also check for apical crowding, that is the effacement of the perineural fat by the muscles. We should also look for Barrett's index, that is either horizontal index or vertical index. In vertical index, we'll add the vertical recti muscle thickness divided by the vertical orbit diameter and into 100. And if it is more than 67%, it's suggestive of apical crowding. So now we have a clinical diagnosis which is confirmed with the radiological signs. So now it's time for treatment. So what is the aim of our treatment? This is the Rendel's curve which shows the natural course of the thyroid eye disease. It has an active phase and a quiescent phase. In active phase, if we start early the treatment, the morbidity will be less. So the 2 things we have to check in these patients are whether the patient is active or in the quiescent stage, and also about the severity. For activity, we can use the clinical activity score. We will have we have to check the patient in the first visit and also in the follow-up visit. These 7 points like pain, swelling and redness of the conjunctiva and eyelids should be checked, and each given a 1 point score. And if the score is more than 3 out of 7 in the first visit and more than 4 out of 10 in the follow-up visit, we will consider it to be active disease. So the severity is defined by UGOGO, that is mild if there is minimal red retraction and minimal extraocular muscle motility defects, and moderate to severe if there is profuse proptosis and if there is extensive extraocular motility disorder, and if it's sight threatening, if it is dysthyroid optic neuropathy and corneal exposure. So this is a nutshell of the treatment of active thyroid eye disease. If it is mild, we will stick into the conservative management with lubricant. Sometimes we may require oral steroids. And in case of moderate to severe thyroid eye disease, we have to start low dose IVMP therapy. If there is suboptimal response, we have to go for low dose radiation along with steroids. And also we can go for immunomodulators. And in case of severe sight-threatening disease, we should give high dose IVMP therapy. If there is suboptimal response, we have to go for early endonasal decompression, endoscopic decompression. So by UGOGO, they have also mentioned along with steroids in case of moderate to severe thyroid eye disease, we can start mycophenol mofetil. And in case methylprednisolone is the primary line of treatment, we can give as an intermediate IVMP therapy with 500 milligram per week for 6 weeks, then reduce to 250 milligram per week for 6 weeks, or high dose we can even start with 750 milligram and reduce to 500 milligram. And in case of dysthyroid optic neuropathy, we have to give 1 gram IVMP dose for 3 days, and then we have to shift into the weekly regime. So we can also give immunomodulators like mycophenol mofetil, cyclosporin, azathioprine and methotrexate. And there is targeted therapies evolving, and orbital radiation like 20 Gay in 10 divided doses over 2 weeks of time can be given. And this is a surgical management, rehabilitatory management for the inactive cases. First we have to do orbital decompression, then if needed, and wait for it to settle, and then do extraocular muscle surgeries and wait, and then do the lid correction surgeries. Thank you.
Thank you, Dr. Soumya. I think that was a fabulous IC. Anyone has any questions from the audience? Over to you, Dr. Angela.
Any questions? Yes. You have to ask any questions.
I wanted to ask Dr. Akshay, you mentioned that you close the orbic and skin in 2 layers. So, just want to know, is there any specific difference if you close in a single layer versus the 2 layers?
Not really, but I close the orbicularis with Vicryl, which additionally scars a little bit more. So just for more than the patient's safety, it's the surgeon's mental peace. And just a point, I think, in general, the philosophy of upper lid bleph has moved away from orbicularis excision. So preservation of as much as orbicularis as possible is considered to be the norm. I do sometimes do excise a little bit, but biting my tongue. I mean, if you see the masters operate like Goldberg and Massey, they absolutely find orbicularis excision to be criminal. So I used to do that, but now I've stopped doing it.
Thank you for that.
Akshay, if you have just a case of preseptal edema without pain, no focus of infection, would you start antibiotics or would you give steroids? One question.
Preseptal edema, I think it depends on the onset. If it's subacute, without pain,
no focus.
I would think of inflammatory rather than infective.
Yeah. Would you give antibiotics?
No, I'd probably give a course of steroids or non-steroidal anti-inflammatory, reassess. But while that is happening, get a thyroid done, because again, thyroid presents in all unusual ways and means. So that would be my...
That is one question. Next is, if the patient is presenting with a little proptosis, defective ocular movements, preseptal edema, would you give steroids along with antibiotics the first day itself, or would you wait for 1 day?
So I
would you
think
take CT scan first day itself?
If you're suspecting cellulitis, so if there is, if there is any sign of motility restriction proptosis, vision or pupillary issues, I would suspect cellulitis. But typically you would see the signs of infection or inflammation in these patients. So yes, then I'd start IV antibiotics, because once it is orbital cellulitis, intravenous antibiotics would
Would
be
you
needed.
start steroids along with antibiotics?
After 48 hours or after documenting
After CT
improvement
scan.
in motility, vision or reduction in proptosis, I start routinely now all orbital cellulitis, especially pediatric cellulitis. I give steroids after 48 hours of antibiotics. Even if no improvement is seen, one dose of Dexa, about 2 or 3 milligram BD, and you would immediately see a rapid improvement, confirming that it is bacterial cellulitis. So I'm now moving
We
towards.
give steroids along with antibiotics and take a CT scan 1 day or 2 day after, so that after the edema subsides, if there is an abscess or something, you can see that and you can plan. Otherwise, there is a generalized edema seen. CT may have to be repeated.
I agree.
So I don't know what your experience.
So I think the main focus, the main reason behind doing a CT preliminary is to just make sure that you're not missing. Or first thing is that 50% of all orbital cellulitis are primarily due to a focus within the orbita or the periorbit, most likely the sinuses. So just I'd be worried if I don't see a filled sinus. So seeing sinusitis in a patient with CT is very reassuring for me, because then I know, okay, it's come right next from the sinus into the orbit.
But
So
then steroids and antibiotics are given. That will come even without a fuss. After 2 weeks it will relieve itself.
I agree. Yeah.
So most of the patients we can avoid a fuss if you give antibiotics and steroids together for 2 weeks. That is our experience in
Yeah, I think there was a paper published from AIMS by Dr. Neelam Pushkar, where they also started giving steroids immediately with antibiotics. And of course, their outcome measure that they saw was the average number of days in hospital and complete normalization of ocular motility. And in both cases, the steroid group had shorter hospital duration stay and early normalization of full ocular motility.
So that's
I
what we
think,
do
yeah, it's a good,
for many years
it's a
now.
good plan. I think our dogma of not starting
documented, but not
steroid
documented, yeah.
immediately in infective cases continues to hold us back. But thank you.
No, it doesn't hold us back.
It holds me back.
Thank you so much for that wonderful session. I call upon Dr. Marian Polly to hand over a memento to our invited speakers. Dr. Akshay Nair, please. Can you pose for the photo? The photo. Oh, you receive. Can you please pose for the photo again quickly? Thank you, Dr. Akshay. I call upon Dr. Fairuz to please receive the memento. And all the speakers, please stay behind for a group picture. And a special thanks to Dr. Sonam too.
Can you turn off the backdrop? Yes, sir. So we have a good photo.
Black. Yes, just do it.